Good evening, everyone. My name is Michelle Holmes, and I am the Director of Sales for Advexia Diagnostics. I'm very happy to welcome and introduce Dr. Wayne Sodano, who is our Director of Clinical Support and Education. Dr. Sodano is a chiropractic physician and, along with so many other credentials, a diplomat of the American Board of Chiropractic Internists, the American Clinical Board of Nutrition. He's a certified functional and integrative medicine practitioner and is board certified in traditional naturopathy. Dr. Sodano is also the director of the Integrative Medicine Education for College of Integrative Medicine and lectures all throughout the world. In fact, he just mentioned that he'll be going to China next month to, and is being welcomed back to speak again. Good evening, Dr. Sodano.
Good evening, Michelle. Thank you so much. So we
certainly
ready to get underway?
Yes.
Okay. All right. Well, welcome everybody. And first, I just want to start out by thanking Advexia Diagnostics for giving me this opportunity to talk. And so we're going to look at the learning objective first. This is what we're going to be going over tonight. And first, I'm going to be reviewing specific laboratory testing for rheumatic diseases, as you can see. Next is the role of gastrointestinal dysbiosis, and that's, in other words, a change in the GI microbiome as a contributing factor to rheumatic disease. So it's some fun stuff to look at. Next is why food can lead to immune hypersensitivity. And remember, anything that causes an aberration of the immune system can lead to rheumatological diseases, autoimmune disease, so forth. So it's important to look at, why food can cause these immune hypersensitivities. And then finally, I'm going to be reviewing the treatment foundations of immune system recovery. So let's get started. So first thing that I want to talk about is in regard to integrative rheumatology, is that, like it reads here, using the science and the art of medicine to help the patient. And that's without regard to putting labels on allopathic, conventional, CAM. All avenues of treatment are the best thing to give to the patient, because treating rheumatic diseases and rheumatological diseases, it requires a multi-system approach using many practitioners as well, such as clinical nutritionists, physical medicine, and even stress management, as you'll see as we talk about, as I go through this webinar tonight. And remember that integrative medicine strategies, they are best given in, excuse me for a minute, that the integrative medicine strategies, it's requisite for the best treatment of chronic illnesses. And what basically that means is that you've got to address the immune system dysfunctions. And the big thing to look at is that link between chronic inflammation and immune system dysfunction. I want you to keep that theme in mind as we progress forward through these slides. So I want to start out by letting you know, first of all, you need to take a comprehensive patient history on your patient. And aside from the general medical history, you've got to do a 7-day dietary history and ask your patient to do a symptom journal as well. It's extremely important. One of the big things with regards to a comprehensive patient history is doing an environmental toxin exposure history. And that's not only at home, in the workplace, but also in the community. And on the bottom of the slide, I don't know if you're familiar with this website. It's a really cool website. It's scorecard.goodguide.com. And what you'll do when you go to that website is plug in the zip code of your patient or yourself, and it's going to give you information on air quality and water quality and also the heavy polluters in that area. So if you know that there's certain environmental toxins in that area, you might want to test your patient for those as well. And last but not least, you definitely want to assess for mold in the home of the patient, because mold can cause immune system depression really big time. There's a lot of that in my area. I live on the East Coast of the U.S., so definitely keep that in mind. So essentially, like it reads on the bottom half of this slide, you need to assess the root cause of the immune system dysfunction, looking for the environmental toxins, the diet, checking the GI system, particularly digestive function, looking for dysbiosis, looking for overt disease, say if the patient has ulcerative colitis, Crohn's disease, celiac disease, you need to account for that, and also for emotional and oxidative stress, and of course exposure to toxins. So that's what we're going to talk about throughout this seminar, or webinar, excuse me. Again, look at that website, by the way. It's a really great website. The other thing that I don't have on the slide that I do want to mention has to do with hyperglycemia. And you may not think of it this way, but with blood sugar dysregulation, when it starts getting like when you're doing a fasting test and you see it 120, 130, you got to think that that patient is under oxidative stress. And here's what happens. High glucose will cause oxidative stress and will also cause chronic inflammation, leading to immune system dysfunction. So it's really important to look at that. And the technical term for that I don't have time to get into tonight is called meta-inflammation, META inflammation. So if you get a chance, write it down and look it up. And that's basically chemicals causing inflammation, not from bacteria and viruses. It's actually cytokines causing that, and high glucose will do that. So please keep sugar dysregulation in mind as well. So the goal is immune system recovery. So, most courses and seminars, they leave the best for last, but I'm going to start the best early, going over the treatment foundations of immune system recovery. So you're going to see the end of the story first, and then I'm going to give you details on the ensuing slides. So let's talk about the treatment foundations for immune system recovery. First, right out of the gate, is dietary assessments, and you need to remove or decrease the antigenic foods, and you can check that out by doing an elimination diet or a modified elimination diet. You definitely need to remove GMO foods, genetically modified foods, because I believe personally, I know there's a lot of back and forth with GMO food, but I like to think of it this way. If a food is genetically modified, it's not found normal in nature. Therefore, it's more than likely antigenic. So that's my take on GMO foods, and to avoid them pretty much at all costs, especially in a patient with immune system dysfunction. And of course, the other is to look for foods that contain environmental toxins. We all know about mercury in certain fish and PCBs and butter, so you want to use organic butter. A good place to look for, if you're not familiar with the foods that are really nasty, is you can go to the Environmental Working Group's website. They have a list of what's known as the Clean 15 and the Dirty Dozen. Again, that's the Environmental Working Group's website. So it's a really great website to look for foods that are toxic and so forth, and foods that are okay to eat that are non-organic, to help your patients out as well. So, by the way, with foods, there are certain foods that maybe we can do this in a follow-up webinar. They're called functional foods that can assist with immune recovery, and I like to use certain mushrooms that are extremely helpful with that. Reishi, Kakashi mushrooms can be very, very helpful, so you might want to write that down as well. And of course, you want to remove toxic sources, even personal care products and home cleaning products, because they're all going to cause damage to the nervous system, the immune system, and the endocrine system. They go at the environmental toxins go after all three of those. So you need to assess for that and remove those toxic products and really clean house on your patient. It's going to help restore the immune system and help relieve these rheumatological diseases and start the patients on their way to restoring health. And of course, next is to consider and restore optimal nutriture or your patient's nutrition. You might want to consider doing a nutritional assessment test, looking for amino acids, looking for vitamin content and minerals. And if they're low, you need to ask yourself what I call like the 5-year-old question is, why are they low? And they're usually low due to malabsorption, which could be GI problems. There could be an increased requirement. So you really need to investigate why these nutrients are low, and not so much just say, okay, you're low, take some of this, but find out why they may be low on these particular nutrients. Usually there's a malabsorption going on, maybe gluten sensitivity, intestinal hyperpermeability, something's going on why they're deficient. Of course, poor diet, which we see all over the place. So the standard American diet's not so good, as you know. So next, you need to look at your patient's weight and their muscle to fat ratio, and the reason being because obesity is associated with a decreased immune status. And basically how that happens is that I want you to think of adipose tissue as an endocrine organ, that's exactly what it is. And like any endocrine organ, it releases chemical messengers called cytokines, and adipose tissue will release two in particular that I want to talk about. One is leptin and the other is adiponectin. Now both of these you can test for on laboratory testing, by the way. So if you're testing for adiponectin, what's going to happen is that level is going to be decreased in patients that have gained weight and are obese. And I want you to think about that as a cytokine or a chemical messenger, and what it does when it's elevated properly, it acts as an anti-inflammatory, it helps with insulin sensitizing, And it also helps as an anti-atherogenic property, in other words, help against cardiovascular disease. So as the patient increases weight, there's going to be a decreased immune status and also a decrease in insulin sensitivity in those patients. So keep that in mind. The other analyte would be leptin. Now, leptin, that's produced by the white adipose tissue, and that helps regulate appetite. And what happens is the patient increases weight or is obese, leptin is going to rise, similar to insulin resistance. And those are two analytes you can take a look for, as well as doing your anthropometric measurements, meaning body mass index, looking at the waist to height ratio. And yes, I said waist to height ratio. It's a little better indicator for metabolic diseases. And if you have a BIA, the bioelectrical impedance machine, which I have, and I love using that, that can give you a real good look at fat mass to muscle mass. So that's the reason why you want to address the obesity or overweight, because getting them back in proportion is going to help with immune system status based on the secretion of these cytokines, also known as adipokines. Hopefully that makes sense to you. And by the way, increase in fat in the body, fat tissue environmental toxins are organic solvents and like to hang out in adipose tissue. So I want you to think of your patient that wakes up in the morning and tells you, every morning I wake up, I have a headache and I feel foggy and everything. Well, here's what happens. At nighttime, the body uses fat for fuel. So in other words, the adipose tissue is being used for fuel, and if it has high levels of toxins in it, the patient is going to feel headachy and foggy. They can't wake up. That's a good indication that there's a high level of environmental toxins, which may lead you to look to do an environmental toxin test as well. So just a little clinical pearl with that. So next is, as you see, restoring gastrointestinal function. And we know to do that, and I'm sure you do, because 70, 75%, 80%, the number keeps changing, but either way, that percentage is the amount of immune system that is in the gut. So the gut has the majority of the immune system in the body is what I'm trying to say. So you've got to check the GI system, and the best way I know to do that is through a comprehensive stool analysis that can give you so much information. And you also, on top of that, want to check is what's known as mucosal. That should be secretory IgA. The S is missing in bold, but it is secretory IgA. And what that does, that's an immunoglobulin that lines the gastrointestinal tract as well as other membranes of the body. And it acts as the first line of defense, meaning that it prevents bad stuff from getting in the body. Think of the GI tract as a tube, and if you ingest food, that it's a tube, and it's preventing bad stuff from getting into circulation. So if that antibody is low, which is produced by a particular enterocyte, it's going to allow bad stuff, bacteria, food allergens, and all that to enter into circulation. And I want to talk for a moment about, well, what would cause a depletion of this immunoglobulin. First and foremost is that there could be damage due to the intestine, say in celiac disease, damage to the enterocytes. Certain drugs can do that, viral infections, poor nutrition can do that. High level of food antigens, antigenic load can depress secretory IgA, causing intestinal hyperpermeability and so forth. Also stress, excess cortisol causes a decrease in the level of secretory IgA. That's why I said it earlier, this is multifactorial. So you really need to look at all of these together as you're going through restoring the immune system, and it'll all work out for you. So the best way to think about all of this is that a decrease in resistance, in other words, a decrease in secretory IgA, that's going to lead to dysbiosis and an increased risk of infection, allergies and diseases, immune system dysfunction. Of course, we're talking about rheumatic diseases, so please keep that in mind. So here we go. So now I want to talk about the last two for this treatment, the foundations for immune system recovery, and that's supporting daily detoxification. We are constantly exposed to toxins every day. They're unavoidable. It's been confirmed that we all have toxins in our body, so you want to do preventive medicine measures for daily detoxification, meaning eating the proper amount of foods, proper magnesium, proper nutrition, and I can get more into that maybe in a later webinar. And by the way, I do requests, so if you want to call Avexia and say, I want Dr. Sodano to talk about something, I'd be happy to put that in the gamut and create a webinar for that as well. Again, looking for environmental toxins. Well, you certainly should consider, environmental toxin evaluation, a laboratory test. A lot of good information on pesticides, herbicides, heavy metals, because you have to find ways to detoxify the body. Next is mind, body, spirit, stress reduction, and that's extremely important. Like I said, stress is going to cause increased cortisol. Increased cortisol is going to lower secretory IgA and also lower the immune system because it's all related. And there's a little saying on the bottom that the body heals with play, the mind heals with laughter, and the spirit heals with joy. So, okay, so now it's on to talking about food and hypersensitivity and immune hypersensitivity to food. And the question becomes, why food? That's kind of like the big question involved here. But I first want to start out by telling you that look at the amount of allergic diseases that are estimated, anywhere from 10 to 25% of the population. So that's pretty huge. And the next thing is talking about young children. We all have maybe our own children or our patients' children that start out having food allergies. And it's like, what's the deal with that? And somehow, they're told, well, they'll outgrow them, and a lot of times they do. And that mechanism is usually of outgrowing them. It's what they call, the baby starts to develop this immunological tolerance. But here's what the take home for me is a couple of things, and for your patients, that prior to pregnancy, preconception, it's a good idea to start doing measures to have the mom change the diet right away before that happens. It can be very, very helpful, and also prenatal care and postnatal care. So you definitely want to plan ahead in that regard, because that can reduce the incidence of infants and young children having these food allergies. So, here we go. So basically, immune hypersensitivity, it refers to a misdirection of the immune reactions. And like it reads on the slide, the immune system doesn't usually mistake food for an aggressive allergen. And here's the reasons why. First, as you see, cooking denatures food. Now, denaturing is the same as what hydrochloric acid does. It takes the protein and it unfolds it so the digestive enzymes can work on it. So that's what cooking does. So in the body, now the proteolytic enzymes, or if you're giving your patient digestive enzymes, or if you're testing them for a stool analysis and find out that they're low, you need to provide those to break the protein into tripeptides, dipeptides, and amino acids. And the reason being is that they're easily absorbed by the small intestine, and they're generally non-antigenic, opposed to indigestion, or not breaking down the proteins, meaning greater than tripeptides. What's going to happen is the body's going to say, I don't recognize that, and it generally can be an antigen. So that's why you want to look at the patient's digestion properly, and also hydrochloric acid levels, and also denaturing and cooking certain foods. Now, some protein escapes, meaning peptides that are higher than tripeptides, more than 4 amino acids strung together, having adequate secretory IgA, that's kind of the backup system, and with a healthy mucosal barrier like I had talked about. So definitely keep that in mind. So think about all of our patients on acid blockers. So what happens when on acid blockers? Like, the food doesn't break down. It doesn't even allow the digestive enzymes to get to the food because there's not enough HCl to expose the protein to, in other words, open up the protein structure. Remember, it's a quaternary structure for those remembering, back in biochemistry. It's exposing the protein to the digestive enzyme, so therefore that protein shows up in the gut, and it's more than likely antigenic, and that's going to cause a degradation in the intestinal mucosa and cause all kinds of problems. These are some of the tests that you may want to consider. Certainly the stool analysis, I mentioned that several times, and I'm going to continue because I get a lot of information about that. The other is testing for SIBO, and that's small intestinal bacterial overgrowth, and the last one is intestinal hyperpermeability. These are really great tests to check for the integrity of the GI system. And just a note on the SIBO test, again, small intestinal bacterial overgrowth. A real clinical pearl here is if you're providing your patients probiotics, and if they're having yogurt and they start saying, you know what, I'm getting a lot of bloating and a lot of gas from the probiotics, and they may be allergic to dairy as well, have a dairy problem, that's usually a sign that SIBO is present, and you need to test for that because that's adding to the already overgrowth of bacteria in the small intestine. So definitely keep that in mind. All right, So here's a table. I want to talk about the response to IgE and IgG food antigen. You should be familiar with these, but we'll go through them. We'll start here. This is IgE, and of course you know that's the immediate reaction, like anaphylactic reaction, some of the early signs. I'll let you kind of cruise through that, but I want to focus in on the mode of action. When IgG is activated, that immediate reaction, there's going to be activation of the mast cells and basophils. They're going to degranulate, and they're going to release histamine, and protease is causing tissue damage. And we all know that the laboratory testing for IgE is pretty specific, and it's very well established. But on the other side is the IgG testing. That's Immunoglobulin G, and that's your delayed allergies. Some call them sensitivities. It kind of goes back and forth. So to me, it doesn't matter. The patient does respond because of an adverse reaction, so you need to know about that. So usually there's no early signs, but maybe 24, 40 hours later, irritability, headache, abdominal pain, fatigue, and it can also be other symptoms as well. But here's what I want you to focus in on. There is also mast cell activation with IgG. It's delayed and maybe certainly not as strong, but it's definitely there. The other thing is known as this immune complex formation. IgG can form an immune complex with the antigen and damage tissue, particularly the blood vessels, cardiovascular disease, and it could damage the joints, the pericardium, and the kidneys. That's why you want to test for this. Now, there are two different tests, and I'll go over those. Just keep them in mind for right now. There's IgG1, that should be a 1 here, or the IgG4 test. And if you're not familiar with it, I'll then explain it during this webinar. And just a quick view of the hypersensitivity reactions to food. There's the immediate reaction that I just talked about. That's the IgG. You all kind of know about that. Next is the type 2. That's the cytotoxic. That's the antibodies. They're going to trigger what's known as complement. Those are proteins released by the liver causing cell damage. And then the third is that immune complex formation. And those can be deposited, like it says over here, in the tissue causing damage. So when you're checking for the immunoglobulin and you know to have patients stay away from particular foods, you're decreasing the amount of these complexes, and that's one of the purposes of doing food allergy testing as well. So I definitely want you to keep that in mind. Next is the one on the bottom is the type 4, that's called cell-mediated, and that's an interesting one because that involves a T cell and activation of macrophages. The take-home with that is gluten and celiac disease. You're going to see this T cell mediated. It's called antigen presenting cell. I don't have time to get into it in this webinar because they don't allow me enough time here. So at any rate, but I want you to focus in on this particular word here, lectins and lectins in the type 2 and type 3 reaction, which I'm going to be talking about. Those are food proteins that are antigens and can cause immune system reaction. And I'll talk with you a lot more about that as we go through. So just definitely keep that in mind because they bind to IgG. Okay, so here's a little closer look, just to put things in the right ballpark. Here is the type 1 reactions right here, IgE, excuse me. Here's the type 2 reactions. Again, there are actually 3 antibodies involved. I'm only going to be talking about the IgG, and this is the immune complexes right here, and this is cell-mediated right here. So this is what happens in the body. I'm going to go over this relatively fast, but I just want to give you an idea, keeping our attention on integrative rheumatology here because this can cause tissue damage is why I'm bringing this up, food allergies, so forth. So here's the immediate reaction. We all know what those are. Here's the IgG antibody. There's an allergen coming into the system. The system is already sensitized. There's degranulation, and that's usually proteases and histamine, so forth. Here's the type 2. Okay. What you have here is a T cell that has an antibody on it, the IgG, and it reacts to a surface antigen on a target cell. Now, a good example of this is rheumatic heart disease. When the individual gets streptococcal infection, well, there is some crossover of the certain parts of the streptococci to certain proteins on the heart muscle, and that's why this antigen complex will go after the heart muscle in rheumatic heart disease. So you want to definitely keep that in mind. Next are these immune complexes, and here is IgG. there's the antigen, and by the way, these are the complement proteins. Think of complement as just painting a target on something as a telling the other parts of the immune system, go after this, it's foreign. So I want you to think of it that way. Now, these complexes, they can get inside the blood vessel walls, they can get inside the pleura, they can get inside the synovial fluid, causing rheumatic, rheumatoid arthritis, so forth. They can actually get into the kidneys, like I said earlier. So anything that decreases the amount of complement immune complexes is going to help in treating the patient. And here is the last one, the type 4. This is a sensitized lymphocyte. Here's the antigen, and that causes some secretion of some cytokines, cellular communicators, and these are the two guys that cause tissue damage, the cytotoxic T cell and also the macrophage. You're going to see this type of reaction in contact dermatitis, also in tuberculosis, by the way. So just real quick, I'm going to kind of buzz through these. These are like exploited views of what I just talked about. There's a mast cell, some primary mediators. There's also some secondary mediators that are released when the antigen touches that antibody, releasing or activating the mast cell, and here they are. So this is what's in the mast cell, this histamine, serotonin. This is their job, vascular permeability, smooth muscle contraction, so it's going to increase the permeability of the blood vessels. That's what's going to cause your swelling. These are the guys that cause damage here, the proteases. They're going to damage the connective tissue, so that's how IgE can actually damage connective tissue as well. And these other primary mediators, they bring eosinophils in and neutrophils in. But down here are the secondary mediators. They're produced inside the cell. Some of them may be familiar to you, the leukotrienes and prostaglandins, certainly other cytokines, but I want to focus in on the leukotrienes and prostaglandins. Like, where do they come from? How are they made? Well, they're made from fatty acids in the cell, particularly in the cell membrane. You may remember the omega-3 and omega-6 fatty acids. They will be drawn into the cell and converted into these leukotrienes and prostaglandins. And by the way, that's where a lot of natural medicine and pharmaceuticals are trying to block these. My suggestion to you is to consider doing a red blood cell fatty acid test to balance out the fatty acids in the body, to balance out the omega-6 and omega-3, and getting a proper inflammation, pro-inflammation and anti-inflammation reaction, because you want a little bit of both, especially if there's tissue injury. You want pro-inflammation to wall off the infection, but you want the anti-inflammatory switch to kick in, and that switch is dependent on having the proper amount of EPA, DHA, and so forth. So kind of keep that in mind. So here's just a quick look at the type 2 reaction again, just a little exploited view. There's a target cell. When the body's trying to get rid of the antibody, hooks onto that. And this is a natural killer cell, macrophage, and also complement for the liver, destroying that target tissue. Again, IgG and IgM antibody is involved in that type of reaction. Yeah, there we go. These are the immune complexes. These are the ones I said can cause a lot of damage because they get deposited into the blood vessels, also into the synovial fluid, and also the kidneys, and that's just an exploited view of that. And again, IgG is involved in that reaction. By the way, I think that these slides are available for you through Avexia. Double check with them. You might be able to get a PDF of these to help you go through these a little bit slower. And here's the hypersensitivity reaction I talked about. That's the contact dermatitis reaction, and that involves a T cell and cytokines and reactions of the macrophages and also the cytotoxic T cells. And you see that in tuberculosis, so definitely contact dermatitis. Remember I said I want to talk a little bit more about lectins. And lectins, they are those proteins that are found on food that can cause a reaction in the body. Now, where they're mainly found, these lectins, they are, again, protein antigens. Beans are the main source of lectins. But also, barley, corn, and rice, and wheat contains a lectin, and that lectin is called gliadin, or gluten, by the way. So they can cause a reaction in the body and can cause a lot of damage to the body. So what I suggest doing, even after doing a food allergy testing, is looking up the foods that are high in lectin and having your patient, particularly if they have rheumatic diseases and so forth, is having them avoid those foods. And the main ones to avoid are the grains, the beans, and also the nightshade family. So that's grains, beans, and nightshade family. Have them avoid that as well. And see if, while they're taking a diary, of a diet diary and also a symptom diary if they're getting better. So hopefully we're still connected. I heard a beep. So, okay. So that's definitely worth trying. And what you want to do, by the way, I have some treatment recommendations for patients with connective tissue disease that you may want to try by prescribing what's known as N-acetylglucosamine. What that will do is that will block the damage to the connective tissue by stopping the immune complexes from damaging that. And if you have a patient that has a lot of urinary tract infections, lectins can be involved in that as well, causing an inflammation, possibly interstitial cystitis. Good idea to prescribe D-mannose and see how they do, because that can block that damage to the inside of the bladder. So keep that in mind. A couple of clinical pearls here for you. Something that doesn't get a whole lot of talk, by the way, is this reaction that I found is reaction to known allergens, say pollens, latex, so forth, with cross-reacting to food. I found this extremely valuable, and what you need to do is obviously do a patient history and find out if there's known allergens to, say, pollen, birch pollen, and so forth, because there can be a cross-reactions to certain foods, and you're not even going to know it. So an example is like birch pollen. If a patient shows up, whether you test for it or if there's a known birch pollen, there can be a cross-reactivity to mango. I find that kind of interesting. If they write down that they have a latex allergy, they may be allergic to bananas or show a reaction to that, also kiwi and mango as well. So look up food cross-reactivity of pollen and food allergens. It's really a neat way to keep pressure off of the immune system. It doesn't necessarily mean they have a reaction, but you're trying to restore the immune system, and you want to use all possible knowledge to keep pressure off the immune systems, and there may be a cross-reaction, like I said, to known allergens in specific foods. So look that up when you get a chance. You can Google that, cross-reactivity of pollens to foods. There's a whole bunch of information on the website for that, so definitely have a look at that. Okay, so just quick review. Here's the classifications of the adverse food reactions. We'll start up at the top. I've talked about these, but it's easier to sometimes see it in graph form. You have immunological reactions and then food intolerances. And remember that they are non-immunological. An example of that would be these metabolic reactions. We all know about lactose intolerance. There could also be intolerance to sulfites in foods as well, like wines and so forth. And it's also this anaphylactoid reaction, and that's a reaction very similar to IgE, by the way, without an IgE event. And that can cause a release of histamine. Some examples of that would be an aspirin allergy. People react to that. Dyes used in radiography and so forth. So those, you need to account for these immunological reactions, particularly histamine reaction. I see a lot of that, and that's a whole webinar in and of itself right there. And, of course, your food allergies, you have IgE and then non-IgE. We talked about those. The one on the bottom is kind of rare, but you know, you never know. Rare ones usually wind up showing up into my office, that's for sure. This is called exercise-induced. It has the food anaphylaxis. What happens is when the individual exercise, the body temperature goes up, and for some reason they can react to food that they ate a couple hours before or immediately after, and they're trying to figure out what's going on with that patient, and that may be the reason, just due to increased body temperature. It's uncommon, but it can happen. So again, try to get the slides here on the PDF and the PowerPoint slides. They can really help you. This is for classifications. I thought I would just put that in there of adverse food reactions, just to kind of get your mind in order of what may be going on with the patient. The antibody-mediated, I talked about that. That's immunoglobulin E. Of course, the cell-mediated non-E, which is IgG. There's celiac disease falls under there. Enterocolitis, enteropathy, proctitis, and then on the bottom is either antibody-mediated or cell-mediated. These are not that common, but they're certainly there. The allergic eosinophilic gastroenteritis and allergic eosinophilic esophagitis. I mean, it's out there, but I just want you to be aware of those. And the final, we talked about the food intolerances, those anaphylactoid reactions I mentioned, strawberries, and it could be aspirin and all kinds of other things, and then the metabolic disorders. You just want to account for these things as well, as what I'm getting at. If your IgG1 and IgG4 test shows up negative, like what else is going on, put this into the mix and of course the idiosyncratic reactions, sulfites, induced asthma, that can cause a whole bunch of problems, especially with wine. If you're looking for certain wines have natural sulfites in it, but you want to make sure either keep your patient away from that or look for wines with no added sulfites, or like it says here, make your own. That's a whole other story for me. So I want to talk a little more about these immunoglobulin subclasses. We're getting near the end, so hang in there. I appreciate it. Hopefully getting some good information here. When you're looking at your laboratory testing, most of IgG you're looking at is IgG1. That's the initial responder to a new antigen. What's going to happen is that usually when IgG1 is formed, just like most things in the body, it breaks down. And what breaks that down is the macrophages that are located in the liver, in the Kupffer cells, and it starts to break it down. So there may not be an immediate reaction because the body's trying to break down the immunoglobulin, just like it breaks down hormones and other chemicals in the body. But when you look over all the way to the right, you're going to see this IgG4. That is an indication of chronic exposure to antigen. So that's kind of like the take-home here. You want to be definitely, when you're looking at laboratory tests, is look at both of these, IgG1 and the IgG4 testing, because this is going to give you an idea of chronic exposure. So the thing about the IgG1 and IgG4, here's kind of the bottom line. I want you to think about the IgG1 antibodies, and usually it's just called IgG testing. They tend to be sticky, and they can be a little more non-selective to antigens. In other words, there could be a little more cross-reactivity and some false positives, so definitely keep that in mind. A lot of times you get these tests back, and it's like the patient is allergic to everything, and they may not necessarily be showing an antibody to all these foods. It may be due to the fact that that initial antibody, IgG1, is a little bit stickier, and there may be some false positives, so keep that in mind. Next is that if you're doing the IgG4 test, remember that that test shows chronic exposure, and generally it's associated with intestinal permeability or hypopermeability, and you definitely want to consider doing a test, again, a stool analysis or testing for intestinal permeability. And on the bottom, I usually get these rotation diets for the patient and all that, and I got to tell you something, my experience, clinical experience, patients follow that thing for about 2 days and they kind of give up. So you definitely just want to give them a very straightforward diet, low antigenic diet, low anti-inflammatory diet. There are plenty out there. I can recommend some in the future that work really well with patients. They have a tough time following these rotation diets. In my experience, you may have better results than I do, but they definitely follow these low antigenic anti-inflammatory diets much better. Just sit down with them with a nutritional counselor, certified clinical nutrition, or yourself. Just sit down with them for an hour, and I think they're going to get it. So keep that in mind. So here is the IgG food testing. Remember, like I said, it has some limitations, and if the patient's still reacting to certain foods and it doesn't show up, remember the non-immunological related allergies, like I talked about, or reactions, like histamine, so forth, intolerance, and they also can be reacting to certain lectins, so you may want to try that low lectin diet like I had talked about. Bottom line is, this IgG testing is great, but you want to look for the underlying cause, fix the immune system, like we talked about, immune system recovery, and I gave you the tools for that. So next is rheumatic diseases and the role of the microbiome. Now, there are two pictures you see here. One, the doc is examining this patient's stomach, and actually it looks like he's checking for an abdominal aortic aneurysm, quite frankly, but the bottom line is we're looking at the role of the GI microbiome. And now you see the teeth here. All this is plaque. I'm sure you're familiar with that. I want you to think of plaque as biofilm that's protecting bacteria around the teeth. Periodontal disease, very related to rheumatoid arthritis and rheumatic diseases. So you need to look at the teeth on your patients doing your physical exam and so forth. So that's what we're going to talk about. So here we go. Here are a list of bacterial species that are related to spondyloarthritis, ankylosing spondylitis, rheumatoid arthritis, and inflammatory bowel disease. So if you do a stool analysis and you pick some of these up, it's very possible this is what you need to treat, because these bacteria and these species are related to these particular diseases. This is documented. So next are the rheumatic diseases. And like it says here, the diagnosis and management depends on the medical history, the symptoms, and the physical exam. And with regard to laboratory testing, there's a lot of tests out there, but many are non-specific. In other words, they're not pathognomonic for any particular single disease, and I'll show you that upcoming. So the main one that you want to focus in on, I'm going to go over a few laboratory testing here so you know how to use them efficiently. The rheumatic diseases, and they're characterized by the presence of one or more autoantibodies, like it says, or immunoglobulins, and they're going to be directed against components of the cell, meaning the surface of the cell, the cytoplasm, the nuclear envelope, or the nucleus itself. And the hallmark test of systemic rheumatic disease is autoantibodies to the nuclear antigens, and that's ANA test. Okay, so here's a list of a whole bunch of systemic rheumatic diseases and related disorders, and there is a whole slew of them. Some of them I'm sure you're familiar with. Lupus, systemic lupus, discoid lupus, lupus-like, drug-induced, Sjogren's disease. By the way, drugs can induce lupus. There are certain drugs, I have a list of them somewhere in one of my books, but it can, so you got to be aware of that. And rheumatoid arthritis, or scleroderma, CREST syndrome. Then there's these mixed connective tissue diseases, meaning we don't know what to call it, so we're going to call it mixed. And then there's systemic vasculitis. I'm pointing these out to you because no matter what you call this, if you go back to the foundations, the treatment foundations I showed you, a lot of these will get better. So just forget the name in a way and just go after restoring the immune system can be extremely helpful using those 7 steps that I showed you with laboratory testing as well. Okay, we're down to the last 3 slides, somewhere around there. So here's some laboratory testing that we can talk about. Rheumatoid factor, I'm sure you heard of that. Here's the normal values, and that is the autoantibody, and it's mostly the IgM antibody, and it's present at about 50 to 95% of adults. And of course, it's increased rheumatoid factor, rheumatoid arthritis, systemic lupus erythematosus, mixed connective tissue disease, Sjogren's. You can read those because I'll give you the slides. So definitely have a look at that. Next one down the line is this anticyclic citrullinated peptide antibodies. That's a mouthful. Here's what happens is that there's antibodies can bind to an amino acid called citrulline. And what happens is that in the joints in rheumatoid arthritic patients, it says, it's spelled wrong, by the way, proteins are going to be transformed in the joint to citrulline. And that's going to cause inflammation. And what happens is that there's going to be antibodies to that. And this test can be used, like it reads here, for early detection of rheumatoid arthritis, or if the rheumatoid factor is below 50 IUs per ml. So you might want to couple these 2 tests together. And of course, I talked about the anti-nuclear antibody test because those are antibodies directed against the nucleic acids and nucleoproteins. But be aware that non-rheumatic diseases can cause a positive reaction as well. So be aware of that. So the bottom line is you want to couple some of these tests together is kind of what I'm getting at. Here's another test for rheumatic diseases. It's the anti-neutrophil cytoplasmic antibodies, and you'll see it here, ANCA, and they can be checked for in the cytoplasmic. There can be perinuclear antibodies and also anti-myeloperoxidase antibodies. There is a myeloperoxidase test I want to tell you about. It's looking for the enzyme, and that's related to cardiovascular disease, so there's 2 different ones. By the way, this one, the anti-myeloperoxidase, this goes along with the anti-neutrophil cytoplasmic antibody testing. So they're very helpful, by the way, this test for vascular diseases. And again, go back to the foundations of treatment like I talked about. Then there's complement that you see here. Now remember, complement, there are a set of these little proteins that are produced by the liver, like I said, and they are, I like to think of them as painting a target on the bad guys so the immune system can go after that. And 2 things you need to realize. Complement can be increased in rheumatic fever, ulcerative colitis, and inflammatory diseases, illnesses, but it can also be decreased in autoimmune diseases. So you got to know which one you're looking at. So you need to know about the increase and decrease. And by the way, this one C4, the complement will split, this is a little side note here, into what's known as C4A. That becomes elevated in Lyme disease if you're not familiar with that. And the last 2, here's non-specific markers, certainly erythrocyte sedimentation rate and C-reactive protein. I think C-reactive protein should be on every single blood test you ever order for any patient all the way because it is a marker of inflammation. Even though it's non-specific, it's letting you know that there's inflammation in the body. and the body's producing a interleukin called interleukin-6 in the liver, causing this reaction of the C-reactive protein. So definitely keep that in mind. And by the way, the C-reactive protein, you know, a lot of times it's like, okay, what is it? Does it have a purpose? And yes, it does. It helps the immune system. That's why it's up. It just doesn't stay up because it's an inflammatory marker. It actually, that protein assists the immune system. So it does have a purpose other than letting you know that there's inflammation. And the final one here is the human leukocyte antigen B27. And that is an antigen that exists on the surface of white blood cells. That's where they found it, why it's called human leukocyte, meaning white blood cell. That's where it was found. And here's the deal. There's genes on chromosome 6 that determine whether that antigen is present or not. If it's present, it's going to show up on the test. When you look for that HLA-B27 test, and it's associated with, like you see here in bold, rheumatoid arthritis and ankylosing spondylitis, and even Graves' disease, by the way. There's a lot of crossover with that HLA. And other things can stimulate that antigen from expressing itself on the gene chromosome 6, and I believe gluten can do that as well. So there is a connection there, gluten sensitivity, and then there's diabetes as well, can stimulate that gene to express itself on chromosome 6, not only ankylosing spondylitis. There's a connection between those diseases. Okay, so hopefully that wasn't too fast. Please get a download of these slides, and if there's anything you need me to talk about in the future, please let me know. It's Dr. Sodano. Thank you so much for listening and for your time. Hello? Hello, hello, hello?
Oh, I'm sorry. Are you there, Dr. Sodano?
Yeah, yes, ma'am. I'm here. Just finished up. Any questions?
Yes, I'm sorry. I had myself on mute there for a minute. I did want to thank you very much, Dr. Sodano, for your presentation tonight. It was excellent. And yeah, I was going to see if anyone out there, you know, wanted to ask you any questions, type them in if you had a minute. And of course, this is being recorded and will be posted to the member resources for anyone who would like to review it again. We also have plenty of other materials there that they can look at. And of course, they can reach you by email and ask the doctor, or they can even reach out to me if you have a question about ordering tests, michelle.holmes@avexiadiagnostics.com. So I'm looking to see if we have any questions so far. I don't see any.
Yeah, I see one that somebody wants to download the slides, I believe, and if you can be happy to make them available. And I think we sent you a PDF of these slides, by the way, and we sent them over to Avexia, so I tell the doc, sure.
Okay, yeah, absolutely. Like I said, this whole presentation will be posted probably by tomorrow on the member dashboard. You know, along with any other materials, but I think they will be able to pull that up and be able to, and if they can't print it or if they need some assistance, certainly contact, we'll get it over to them.
Okay. Yeah, I see another question coming through. Yeah, suggestions for low antigenic diet and where to get foods. Here's what I do. I think it's Dr. Garcia, if you're listening here, sure. I get a little sneaky about this, to tell you the truth. I'm going to tell you what I do. I like to use Mark Hyman's book. It's called the Blood Sugar Solution Recipe Cookbook. That's one that I like to use, basically, because I tell the patients, you know what, just eat the foods in here. I'll double check everything, make sure they're not allergic to any of the foods. But the majority of the foods that's recommended in that recipe cookbook are low antigenic, anti-inflammatory, and very high in herbal medicine. So I found that'd be extremely helpful. There are other ones as well.
Great.
Okay, he said great. Okay, all right, Dr. Yeah, I can see it showing up on here, so it's pretty cool. Okay, so I'm heading them off. Okay. All right. All right, looks like we're good. What do you think?
Yeah, I think that's it. I think that we're all set. And again, if people have some follow-up questions, please don't hesitate to contact us at any time.
Yep, yeah, you bet. Okay, Michelle, thank you so much.
All right. Have a good night, Dr. Sodano.
Okay.
All right. Good night.
Bye-bye.